Well, hello everybody. I'm Dr. Matthew Abraham, and today we're going to talk about a common disorder called obstructive sleep apnea. Believe it or not, this is an extremely common problem that most people weren't even aware of it being an issue in the past. This problem, the definition of this problem, simply describing it, is basically when you go to bed at night, the airway can get relaxed, and what will happen is it'll start to fall down a little bit when you're asleep. And so if that happens, you start to have shallow airflow or blockage of airflow, which can cause events and responses that have impact on health. The things that you'll notice as a patient or as in the population are things such as loud snoring. You'll notice that there's maybe gasping or choking at night. You'll find that people sometimes have increased urination or other symptoms at night that can be occurring. These are common symptoms. One of the things that people don't realize, sometimes excessive sweating can also be a sign of this condition. So this problem is extremely common. We usually see people snoring, and we usually think it didn't matter, and we thought it didn't matter in the past, but the reality is snoring is a symptom of something that can be actually dangerous and cause harm. If you can see this slide, this is an older slide that says there's about 18 million people in America that have the diagnosis even as we speak, and that number is probably actually low. It's probably a higher percentage of people than that even implies. And that's just some old information saying that, hey, this problem is extremely common and extremely underdiagnosed. More commonly, you'll find this condition in people that are older, or if you're heavier. If you have a short and thick neck, these are signs that can be an indication that you could have this problem. There's also some characteristics that you could have that also can increase your likelihood of having this condition. One is if you have an overbite, for example. If the chin is further back, well, that can cause crowding of the airway, and that's a very common issue that can be affected with this. If you have a large tongue, that can cause crowding of the airway. Now basically when I tell my patients when I see you in initial visits, the way I explain this condition is a very simplistic way. Basically, if we're making a noise at night such as this, a snoring noise, if we think about that, does that sound like air is moving easily? It isn't. It means there's an obstruction of the flow of air, and it happens because the airway has relaxed and fallen down, a little bit or a lot. And so if it falls down like over here, once I get used to this little thing, let's see what we got. Right here, you can see it gets more narrow. Well, if it's narrow, you can get turbulence or vibrations. Those vibrations are the noise, which is snoring. Snoring is never normal. I want to make that clear. It's obstruction of airflow. Now, it doesn't have to be pathologic. What I mean by that is if there's some narrowing of the airway and there's a snoring that is occurring, if all the air gets into my chest and all the air gets out, at that point, it's just noise. So it's not necessarily pathologic, but it's noise. Now, your partner may not like it, but the thing is it may not hurt you at that point. But here's the problem. If that airway gets too narrow, all right, it's too small because it's relaxed and you're asleep. Now, technically, there doesn't have to be noise. It's just too small. If you're breathing through that tube that's too small, what's going to happen to that patient's oxygen level after a while? Would you get all the air you need? That's right. You're basically obstructing the flow of air, and you're basically suffocating. And so if you're sleeping and suffocating, and your oxygen level is going down, something has to happen, or none of us would ever make it. But something very simple happens. If you're asleep and not breathing effectively, what is your brain going to tell you to do? It's exactly right. But the catch is you won't be aware of it. You won't have any knowledge of it. We breathe all day long and don't remember it. It's an autonomic response. The brain takes care of the problem, tells you to breathe and not to breathe based upon oxygen needs. So when you're sleeping and basically having these events and basically suffocating, the brain physically wakes up for 2 or 3 seconds. It has to do that for a very simple reason. It has to increase the muscle tone so that you can take a deeper breath to get the air in and out. So when it does that, you open your airway, you take a deep breath just like this. Back to sleep. Now it can sound like a snort, it can sound more deep, but it's going to be a response to these events. So imagine you're sleeping and that happens without your knowledge, but it starts to happen 20, 30 times an hour all night long, with desaturations or without. How do you think you'd wake up feeling the next day? You wouldn't recover. And imagine if there's severe desaturations associated with these events where the oxygen is dropping significantly. What type of stress could that put on your heart? That's what we've learned. What's happened over the past decade is the research has come in to show, by the way, this is retroagnathia. It's a way to explain the jaw structure. If you have an overbite like this person over here, that can put the tongue further back, which can cause more obstruction. Now, what's happened over the recent time is that we've learned that this problem is very significant. It causes significant cardiac stress. Basically, it can actually lead to the development of hypertension. It's linked to recurrence of atrial fibrillation. There's a strong correlation between recurrent strokes. And the weird thing about, for example, with strokes is no matter what the cause of the stroke, whether it be a fib or some vascular anomaly, doesn't matter. If you have apnea, the chance of a recurrent stroke is close to 7-fold the general population. So it's things that we didn't correlate. So it's unusual that that's the case, but that is the case. Now, basically, what we're trying to emphasize to people is that this is a serious condition. Obstructive sleep apnea syndrome has impact on health and impact on life expectancy. Some research shows that life expectancy can be decreased by close to 7 years if it's untreated. But the quality of life is what's severely reduced. There can be significant improvements in your quality of life and functioning if this is treated. Now, I do apologize, I'm going off the slides a little bit. I haven't looked at this slide in about 4 years. So, so I'm going to try to get through it. Now, one thing we want to talk about is this is what apnea is. It's a condition that's related to obstruction of the flow of air. It has impact on health. It's extremely important to treat in most factors of health. Before I tell you this, one interesting fact, I was just thinking about something that's not on the slides. Imagine you're in a heart doctor's office. Many of us have cardiologists that see us, correct? What percentage of cardiology patients would you expect to have obstructive sleep apnea syndrome? Without asking a question if they snore, without asking if they have a condition or a problem, what percentage of patients with a cardiologist would have apnea? It's close to 70%. They did studies up north taking cardiac practice and said, let's study all the patients and see what percentage would have apnea. Close to 70% of those patients had the condition. And so what's happening is there's a huge screening process that's occurring now with people being evaluated and treated. I just think that's an important fact to know. It is that common. In a family practice clinic, which is still not the general population, up to 25% of the patients have apnea. Because remember, if you have a doctor, you're not in the general population. So it is unusually common. Now, the way you would look for this condition is you want to test for it. You want to prove it. You don't want to say, my husband's snoring, he's got to have it. It's important, but you want to know it's there. You want to know how bad it is. What's important about this diagnosis is that this diagnosis has a very wide spectrum of disease, let's say. You have stuff over here that could kill you. And I've firsthand friends that actually passed away at 39 because this probably took his life. Thought it was benign, he was morbidly obese, it almost definitely was the cause. But you have conditions over here where it's a lot of noise and not a big deal, except for your partners wanting to beat you up because you're snoring too much. But the problem is the diagnosis matters because if you have a moderate or severe case, it is extremely important to treat, or it can make the other conditions you're trying to take care of not recover or respond appropriately to the treatments that you're doing. So diagnosis is very important, and a clear diagnosis, to me, is even more important for the severity reasons. How do we do it? How do we study you? One of the ways we do it is what's called a sleep study. I mean, that's the general term, but it's called polysomnography. All this is a test to observe what happens when you're asleep, to see if you're awake or asleep with brain waves, because we're not going to say you're asleep by what you look like. You could close your eyes. We want to know you're asleep, and we'll look at the stages of sleep that you're in. There's a shallow stage of sleep called N1. There's the most common stage of sleep, N2, and then you have a dream state, you have a deep sleep. But these are all terms that we use for observations of what occurs during the sleep process. And these things cycle through the night. We're going to look at the brain waves. We're going to look at the cardiac function. We're going to look for oxygen levels. We're going to look for movements even. Some people have parasomnias that can be occurring. But that's an in-lab study to look at all these events. This is actually what we look at, the squiggly lines, that when you sleep here, we're going to look at these squiggly lines to know what's happening to the patients. But basically, we're going to look to see, if we look right here, these are electrodes that are going to let us see the brain waves for eye movements and the heart rhythm. And this is flow monitoring and then oxygen levels. This is just an idea of that we actually look at true parameters to make this condition or to identify the condition. Let's see. Basically, one of the things that's intriguing is that in dream state, for example, everybody talks about dream state. The irony about dream state is the way it was diagnosed was simply an observation. If you think about it, when they were watching people sleep, they're saying, what are these stages of sleep? Well, they looked up and they see this guy's eyes moving all over the place. So, well, man, that's rapid eye movement. So that's how he got REM sleep. Just observations. So it wasn't really a scientific, but an observational finding, and then they started correlating more information to it. But if you look up here, you'll have these rapid movements of these squiggly lines up and down. Well, that indicates rapid movement of eye movement. That's what it means. And so that's how you actually know they're in dream state, the term that is used for dream state. One little tidbit is that not all dreams happen in dream state. You can have dreams outside of the dream state also. It's just that the majority of dream states appear to occur during that time of sleep. When we study you in the lab, we use specific criteria to make a diagnosis. We have to have desaturations associated with compromise of airflow to a certain degree, with or without arousals to make a call of an apnea or hypopnea. So when you get a sleep, if you have a sleep study, they're going to give you reports saying you have an apnea-hypopnea index that is elevated or not. What is that? Well, apnea, by definition, means you have to have the cessation of airflow. It has to be no movement, maybe because the airway is completely collapsed and you can't move it. And then there's a response to that with a desaturation or an arousal. That's an apnea. That's a true apnea. But the more common events are called hypopneas, which are more about shallow airflow. Same problem, though, it's just that it's not completely collapsed. So there's a compromise of the flow of air, and then there's a response, whether desaturation or arousal, and those are hypopneas. You combine those per hour, and you have an apnea-hypopnea index. So when you see that, that's how we look at severity. Greater than 30 events an hour is considered severe. Less than 5 is considered mild. Now, I will tell you there is some gray area in there because if you have 15 events an hour with severe desaturations, well, that's not really mild. If you have 30 events an hour with mild desaturations, it's still important, but it's not as dangerous as someone has severe desaturations of oxygen. Still, it is important to treat and causes harm and has been proven to do so. If interested, this is basically what we look at. Right here, if you see this flat line right here, how it's moving up and down and then it gets flat, well, that's indicating that the flow is compromised at this point. And when we're looking at this, we'll see an oxygen change or a brain wave arousal. That would be considered an apneic event on the actual physiology, on the sleep study itself. If you look at this one right here, there's like a smaller line. It's a little bit less than up in here, but it's not completely stopped. Well, that's a hypopnea. That's what we mean. There's no movement versus a little bit less movement. Pathophysiology, that's a lot of stuff in there, I know. And I just put this up here to give an idea. When they've done the research on this condition, they've learned a lot of physiologic parameters that they found out were significant and harmful, a lot more than they probably expected. This condition has impact on endothelial factors, which means clotting factors. It has an effect on sedimentation rates. Basically, these terms are related to, has anybody heard of the metabolic syndrome? That's one of the terms they throw out where you have high cholesterol, diabetes, obesity. They all kind of link into each other and they all affect each other. Well, this condition, obstructive sleep apnea, also affects a lot of the intermediaries that affect the other conditions. Basically, they all hurt each other. You have to treat all this to have a better response if you treat any of it. You don't want to leave something isolated. I'm not going to go into detail because I think this will be a little bit more complicated than y'all want to hear. But the reality is, simple effect, it affects your heart, it affects breathing, it affects clotting, it affects coagulability, it affects sedimentation rates and inflammation. And that's not good. And that's another one that I know y'all don't want to do. but basically it's a big loop. Everything's affected. If you have heart failure or high blood pressure, it's important to treat this. If you have strokes, it's important to treat this. I just said that, we'll go. These are some slides that show that these outcomes over 7 years. This was done years ago, and they showed that if you didn't treat this condition, the chance of cardiovascular compromise or disease was exponentially higher than the general population. So if you have apnea and you don't treat it for 10 years compared to a population that does not have apnea, all these events were much higher. Cardiovascular events, hypertension, coronary disease, strokes, everything. And that's why now that this research has come into effect, we're treating the majority of the patients. A neat little thing about AFib. Right now, the electrophysiologists, the cardiologists that cardiovert patients or treat patients are seeing almost every patient that has AFib. Why? If you treat an AFib patient or cardioavert that patient but don't treat the apnea, there's a 82% chance of recurrence of AFib. I mean, so if you don't treat it, it's probably going to come back. Now, if you don't have AFib, don't have apnea, and have AFib by itself, you got a 50% chance of recurrence. Now, if you treat the apnea and treat the AFib, the recurrence drops to 40%, which is almost half of the general population. So it's extremely important to treat for AFib. And so now I'm receiving all the patients with arrhythmias. I mean, almost every patient has arrhythmias are being screened. So basically, what are the treatment options? Well, there are several things that cause the condition. Weight gain, the jaw, the structure, the tongue. There's mechanical issues. So basically, how do we treat this? Every treatment for apnea does the same thing. It prevents the airway from collapsing one way or another. Whether it be mechanical by pulling the jaw forward, let's say, to open the airway, whether it be putting pressure in the airway to keep the airway open, whether it be surgery to remove all the tissue so that the airway is open, or if we lose weight and the airway stays open because the weight doesn't collapse the airway. All these things can help. But the gold standard is the CPAP device. What is that? Continuous positive airway pressure. We'll get to this. All right, I'll explain it. Basically, CPAP is the gold standard. All that device does is simply put pressurized air into the airway, constant positive airway pressure. The airway is pushed open to prevent the collapse, and then you're able to move air in and out effectively. By far the most successful treatment. Probably about a 70% success rate with that device. Other options include cut out the top of the palate. The fancy name is UPPP, uvulopalatopharyngeoplasty. You also remove the tonsils, but success rate is lower. I usually save surgery for secondary treatments because the success rate is not as high, but if you have cases that do not succeed in other treatment options, and sometimes you have those, you need to have these other options to reduce the risk, because these procedures will at least reduce the severity of the condition. There's also more significant surgeries where you actually pull the jaw hole forward. I mean, they actually cut the jaw, pull it forward. You'd save those for very severe cases without any treatment options. Oh, and also, believe it or not, tracheostomies. You could put a trach. Now, obviously, that's not a normal procedure for this condition. I've only had 2 patients where I've done a trach for this condition, and I've been doing this for 15 years. And so one of them was a lady that I never would have expected had apnea. Very thin, petite French lady. Did a study, horrendously severe disease. It still stuns me how severe it was. She had such a small airway. And I tried everything. We did BiPAP, CPAP. She never got comfortable, and she felt horrible. And she felt sickly. She had enough, and she said, I'm doing a trach. She did the trach and came back feeling like 100% better. Why would a trach work? Because it goes below the area of obstruction. See, the obstructions all up here, so when you do a trach, there is no obstruction of airflow. Now, that is not the normal. I mean, it was just an unusual case. But it's remarkable how much it helped her, and it was so severe for her that she didn't care anymore, and her life is better for her. Now, one other unique other option that's out there is called a mandibular advancement device. You're going to see a lot of advertising about this, and I do think they have a place in this field. I think it's a good option for people that don't do well with CPAP, or it's a good option for people that have very mild disease if they want to consider this option. What this is a dental device that a dentist would build that you put in your mouth, that you would bite down, and it would pull that bottom jaw forward. Now remember, this is about the airway falling back. So if the jaw is forward, you would think that it would pull the tissue open to allow air to move effectively to reduce these events. In 30%, I think it does work in some cases. I find the success rate, in my opinion, is about 30% to tolerate and get benefit with it. So it definitely has a place and is a good option for treatment in milder cases. In my opinion, and I've been doing this for about 15 years, I truly believe the machine is the best way to go. As odd as that sounds, we go, well, why would you want to wear this mask? The reality is the vast majority of my patients, from top to bottom, highest success rate, highest compliance rate, and the most benefit. So I go with the machine. And not only that, I have the problem. I'm on a machine. There's a reason, because it works. It's the most effective treatment. Never would have thought I had it, by the way. I was in this field for 3 years before I caught on. I didn't snore. I thought you had to snore. I thought you had to be morbidly obese. I was learning. Well, I did a study, and I had apnea. All those years I thought I had insomnia and just fatigue. It was apnea. My wife still says I'm crazy, but I've got apnea. So the point is it matters, and the treatment truly helps people. And so it's something that we want to treat, and we definitely want to get people involved and active and in here to get treated and evaluated. I think that's good right there. Questions? Yes, sir.
The dream machine you just showed.
Yes.
Explain some of the information that comes out of that when you push the button.
Oh, that's a good question. Basically, there are different companies that have their machines. This one is called the Respironics. I don't have any ties to anybody, but there's also ResMed and so forth. Most of these machines will have data that you can ascertain from them. Basically, when we put you on a CPAP or a device, I personally always give heated humidification. And this will go into the question about what's on it. Why do I do that? The majority of patients require moisture to not dry out with a constant pressure. Now, there's a small subset of patients that really don't need the humidifier, but that's a very small percentage. What I do is I give everybody the humidifier, because if you don't get people comfortable at first, they may not succeed later on. So we try to get everything in there first to give them a better chance of success. So what does the machine have that can adjust or change or tweak, and what information can we get out of it once you get on the device is basically what this question is. One, moisture. Very important. For me, I have to have it. There are heat levels you can adjust on machines, up or down. The higher the heat, the more that you'll get humidity and moisture to prevent drying out. Sometimes you might overshoot it and you can come down on the heat. That's adjustable by the patients. It may change winter to summer. There's also other things that can be done that are slight mechanisms of release mechanisms, make it a little bit easier to blow out. This machine may have access to the patient. Some do, some do not. Sometimes we have to change ourselves. Other information that this will give you is leak values. In other words, when we put this machine or this CPAP on you, this mask goes here. Either covers your nose or in your nose, or over your mouth and your nose, depending on what you need. But the machine does the work. Well, if that mask isn't sealed correctly and there's a very high leak value, that means it may not work effectively. You could dry out, you may still have vents, but it's got a seal. And so this information on this dashboard will give you an idea if there's leaks or problems of that nature. The other thing this will give you is compliance. Are you using it? I'll get patients say, I'm using it all the time. You open up the compliance data 3 times in a month. Well, that's not exactly all the time. And we have that discussion at that point. So then I go back to the study, go, look, here's your study. Here's why you have to do this. And then most of the time I can nudge them a little bit and get them onto the machine, and eventually they'll do better. Other things that this would have, let's see, we talked about the heated humidification, we talked about the compliance data, the leak values. Those are the main things on it that you can adjust. Any other questions specifically about that?